If you do not have tickets yet to come see Blessing Chimanga and his incredible band tonight at the Foundry from 8 to 11 p.m., you can scan your QR code or just come to the door, and I'm sure you could get tickets there. It's 6239 B Street with appetizers, drinks, photo booth, silent auction, dancing, and general uproarious fun. So please, please, please come and help us celebrate and just have a great time together to close out on this day. And then tomorrow we have our Sunrise Memorial, remembering the women that have passed from gynecologic cancer. That's going to be at 10 a.m. tomorrow at Fox Hollow. And so if you are up for it, we welcome you to join us for that as well. So I think we might have everybody we're going to have for our afternoon session. I'm really excited about these last three talks. We're going to step away from the hard medical science and into some big issues, big, that we face in healthcare, but also that we face as humans, and then end with a closing, really inspirational talk about some of the great work that's being done both here in Alaska and internationally. So, Dr. Khabele, please come back, and we look forward to hearing about striving for health equity in the United States today.
Thank you. So, striving is a good thing in a way, because we're always striving to do better. But I'm kind of ambivalent about that word because I think it probably needs to be a lot stronger than striving. And I couldn't think of a better word, but I do want us to just reflect. February is Black History Month, and this is a quote from the Reverend Dr. Martin Luther King Jr. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And to me, this is one of the reasons I do what I do, to try to address the inequalities and injustice that our patients face in healthcare. So in 2003, the National Academy of Medicine, which is the Institute of Medicine, published this white paper confronting racial and ethnic disparities in healthcare. It was called Unequal Treatment. And unfortunately, we're still dealing with the same issues around unequal treatment to date. And these are historic, but I do like to use this snippet from this book to just remind us what the term disparities means. Disparity does not mean difference. So we spent a lot of time today talking about personalized medicine and what is important for an individual patient sitting in front of us. That is a difference. That has to do with the clinical appropriateness. That has to do with the biology or the molecular features of the tumor. Those are differences that are clinical and biological differences that we need to recognize, we need to acknowledge, and really impact care. Sometimes there's an overlap between the biology and the ecology of healthcare systems and discrimination. And that's where the disparity comes in. That you're getting a treatment not because it's the right treatment for you, but you're getting a treatment perhaps because you didn't have access to the correct treatment because of where you live, your zip code, and your access. And so that's what the disparity means. We now know, or we've known for a while, and we need to keep remembering as healthcare costs increase exponentially, that there's a societal cost to inequity. It's not just a financial cost, but I think about living in a state like Missouri, I've lived in Missouri, Kansas, and Tennessee. And these are states, um, not quite as vast lands as Alaska with low populations. But for instance, the state of Kansas, there are a few major cities, but then, there are counties where you maybe have 200 people in a county. And so direct access to health care, as happens in Alaska, may be really, really hard. So what happens is the people end up delaying care because they don't have access to it and end up arriving in the emergency room in crisis. Well, the cost to the individual is high, and then the cost to the healthcare system is high because you haven't been able to intervene early enough or soon enough. Health disparities cost us in care variation, as I was trying to describe just now, where you're not giving the same quality and access to care, and that changes how we're delivering the care, and we may end up not giving the same quality of care. And then we have this whole undercurrent of things that impact the care between patient and providers' attitudes and beliefs, health literacy, and patients' ability to interact with the care. We had some good news this year as far as cancer, declining in incidence in most cancers except for endometrial cancer in the United States. And we also have good news that more and more people are living with a diagnosis of cancer. And the American Cancer Society this year published that there's a 70% 5-year survival for cancers, which would have been unheard of even 20 years ago. So there is good progress. However, there are still hundreds of thousands of people living with cancer and too many people dying from cancer. And there are huge disparities in how this happens. So the American Association for Cancer Research has published reports on cancer disparities. This is their second report. They had one, I think, in 2022. And what they have done is really taken the Institute of Medicine's kind of basic principles of healthcare disparities and expanded it out to really think about more than just the individual, the provider, but also society. They also outline the fact that the populations who experience cancer disparities are not limited to race and ethnicity. Elderly populations experience more disparities in some cases. Some regional disparities and geographic disparities occur. There are disparities with people who have different abilities and physical abilities and mental abilities, and people who are incarcerated. I'm going to focus mostly on racial and ethnic disparities, and mostly disparities amongst Black women, because unfortunately we're almost 10 years from this particular publication from the American Cancer Society to show that really these disparities persist for Black women, whether it's 5-year survival for cervical cancer, which is the most preventable, 5-year survival for endometrial cancer, which is the most common gynecological cancer and has become the most lethal, and disparities in ovarian cancer, which is the second most lethal. And this is something that it really has not changed. It has just been intractable. And my frustration is I keep showing these slides, and we need to figure out ways how to not just document and talk about the disparities, but what we're going to do about them. I do want to pause here, and I showed you the good news from the American Cancer Society that there's excellent survival rates for most cancers, but uterine cancer is the only major cancer with rising incidence and mortality. So there's this increase in new cases of endometrial cancer in the United States, and there's also increasing deaths. About 1.3% increase in new cases over the past 10 years, and a 1.6% increase in mortality from endometrial cancer. Endometrial cancer has the highest racial disparity as well. And so although incidence is very similar amongst race and ethnicity, racial and ethnic populations, Black women are 2 to 3 times more likely to die from endometrial cancer. And this is even correcting for hysterectomy rates. So if you look at the graph that's, so the star is by the mortality rates, and then the graph next to it, the highest rates of death are in Black women. So that's at the very, very top. There are also disparities in diagnosing endometrial cancer. So Dr. Guntapalli had talked about ultrasound and looking at the endometrial stripe or the thickness of the endometrial stripe to help us decide whether a patient should go for additional testing. This is data published by Dr. Kemi Dahl, who's an expert in endometrial cancer research and care. And she has published and shown that the transvaginal ultrasound, where we're measuring the thickness of the endometrium, really misses cases amongst Black women for a couple of reasons. One is Black women are more likely to have fibroids, which are benign, non-cancerous tumors of the muscle wall of the uterus, and so that distorts the uterus, so you're not able to get an accurate measurement of the lining of the uterus or the endometrium. And then the second reason is that the most common type of endometrial cancer is related to overproduction of hormones, estrogen in particular. But Black women are more likely to be diagnosed with the type of endometrial cancer that's more aggressive, that looks more like ovarian cancer or has more aggressive features and is not necessarily hormone responsive. And then when we look at molecular profiles, we had 2 really great talks on molecular profiles of endometrial cancer and how we're using these 4 molecular types to help us determine these differences, to help us determine the types of treatment. We see that the more aggressive subtypes of uterine cancer are much more common amongst Black women. So the serous histology, high-grade serous histology that looks very similar to ovarian cancer, it's more, when they compared tumors from Black women to white women, serous histology was found more commonly amongst Black women, 58% of the Black patients that they looked at. Carcinoma, 25% versus 16% in white patients. And so that's something that's important to take into consideration as well. And this information may not be widely appreciated. So most people who are diagnosing endometrial cancer, it's mostly diagnosed by a general gynecologist who may or may not know this information and may think, oh, the endometrial stripe is 3 millimeters, patient has fibroids. Fibroids are common and may not be prompted to then take the next step and offer a biopsy, a diagnostic test. So it's important that we get this information out there. There are multiple barriers to care, as we talked about a little bit and I alluded to. There's the individual level barriers to care where it is education, culture, zip code. It's the doctor, the individual doctor-provider relationship could be a barrier to care, a lack of awareness. And then there are institutional and structural barriers to care. The zip code belongs in this section. And so I do have to talk about, especially now, that there are many people who experience or have a perception of experiencing, feeling, being treated unfairly when they enter a healthcare system. And that perception and that feeling is disproportionate amongst Black, Alaskan, Native, and American Indian, Hispanic, and Asian patients at a much greater rate than with white patients. And so that's something to consider as well. So I want to break out these systemic factors and the disparity, and then offer up some strategies. And I still think many of these strategies, we wrote about this over a decade ago, and I think many of these strategies are still important. I'm not sure we're really implementing them in a way that's helping. And in fact, I feel like in many ways, as healthcare systems, we're going in the opposite direction. So when we think about low capacity geographic region, and the entire state of Alaska is a low capacity geographic region, you partner with specialized and regional referral centers. So we're here. Providence is a regional referral center. We have 3 gynecologic oncologists for the entire state. You're going to get the referrals, but you're going to partner with the people who are providing care in other parts of the state. If they don't have enough volume or expertise, they're going to refer patients to you, and you're going to have that partnership. And that's really important. But how do we make that a systemic or systemize that? We have not done that in the United States. So in other countries, there is a national system for organizing care so that it is not something we're piecing together, which I find that we do in the United States, where we're sort of piecing together these relationships as opposed to making it sort of a national course. We have lots and lots of problems with insurance policies and care. From Medicaid to Medicare, we finally expanded Medicaid to cover clinical trials, but it's still not enough. And so working on the financial toxicity of care is super, super important. So even patients who have really good insurance, people are paying so much for getting the standard of care. And how are we going to address that as a country and as healthcare costs continue to rise? So there are physician factors. Of course, there are physician factors as far as having the expertise to take care of patients who have gynecological cancers. We have lots of places where it's either a low volume surgeon or a non-specialist who's taking care of people or diagnosing people with cancer and maybe performing a surgery that they're not comfortable performing. And so increased education and awareness, surgical coaching, surgical training, because gynecologic oncologists can't always be everywhere. And then setting a standard to then say, you reach a threshold, if you can't do this, if you can't offer this care, let's find a system to get patients to the care they need. And then, the perception of bias exists amongst patients, and I've got to say, there is bias in clinical decision making. All of us carry some level of bias, but I must say that there are biases that people have in medicine when they're taking care of certain types of patients. And we have to constantly be vigilant about that and incorporate topics into national meetings. Even this one topic I talked to you about ultrasound, that's something that there's not a lot of awareness about. I want to pause a little bit and just talk about a bias that occurs not in cancer but in transplant. So, for instance, kidney disease impacts so many people. It's very, very common. And transplant, if you have chronic kidney disease, should be offered. It's offered less to Black patients, in part because there are not enough donors, but there are all these things that get layered on. Does that patient have a supportive family that can help bring them to and from and then you layer on all this stuff and you make assumptions about certain patients that may or may not be true. So to counter some of this bias in clinical decision making, we need to continue to train a more diverse workforce and incorporate training and awareness into our meetings. Encourage participation in clinical trials and don't assume that the patients who come to see you are not interested in clinical trials. So I'll give you a few stereotypes that may occur. I alluded to this a little bit earlier, that a black woman has a pelvic mass. A lot of people automatically assume it's just a fibroid, it's a benign tumor, and these are so common, we don't need to work it up, okay? And so I think that not only do you have to have awareness and education about working this up and making sure if somebody has abnormal bleeding and is anemic and has a fibroid, you might want to do an endometrial biopsy to make sure you're not missing endometrial cancer. You might want to do a scan to make sure you're not missing ovarian cancer. I've encountered all of these physician stereotypes amongst colleagues. So what I'm telling you are hypotheticals, but not. BRCA mutations are not common amongst black women. Well, actually, they're just as common in that population as other populations, and genetic counseling and testing needs to be offered as standard of care if there's a diagnosis of ovarian cancer. And we need to take good family histories because these types of cancers, even if it's not a BRCA mutation, can run in families. Gynecologic cancers can be inherited, or risk for gynecologic cancers can be inherited. And then this is really important to me because a lot of, I've encountered this in a lot of places where people assume that because it is a black patient, that she is not willing or is not interested in a clinical trial or interested in chemotherapy or immunotherapy. And I think that for people who don't understand chemotherapy or immunotherapy, sometimes it does sound scary, or a clinical trial does sound like you're going to be a guinea pig. But when you put it in the context of this is part of standard of care and you have developed that dialogue of those difficult conversations and you hear and work through some of the patient's fears, I think this is something that can definitely be countered and overcome. I think that a big reason patients don't participate in clinical trials is sometimes they're not eligible for a clinical trial because of other conditions like hypertension and diabetes that are comorbidities or co-conditions that are very common amongst black patients. So those are things that we need to address. And patient factors, some in their control, some not. In St. Louis, the zip code of where you live is such a strong determinant, social determinant of your health. It is amazing. It is unbelievable. In the city of St. Louis, there's a street called Delmar Boulevard, and north of Delmar and south of Delmar is a social determinant. North of Delmar, you're 2 to 3 times more likely to have poor health and have some sort of increased risk of cancer and increased risk of death from cancer versus below the Delmar. We call it the Delmar Divide in St. Louis. And part of it is from historical redlining, no grocery stores, poor housing, poor education. And what we do know about the St. Louis region is there was testing for the atomic bomb in that region. And so now there was radiation waste from that. And we actually, there's a law in place now that people who lived in certain zip codes can now go for compensation and be paid for. Their families can now get payment for having lived in those areas where they had exposure to this radiation waste. So that is happening now, and they have 12 months to submit paperwork to show that they lived in a zip code. Either they personally or somebody in their family, a first-degree relative, had cancer. They only needed to have lived in that zip code for a few years during this certain period of time. And they still have not completely cleared out the radiation waste, by the way. So there's certainly definitely geographic zip code areas and environmental reasons why people are at higher risk for developing cancers. developing programs to reach underserved populations. Sightman Cancer Center has a mammogram van that actually, it's a huge bus that goes to these neighborhoods, and we've shown that we've decreased the lag time for getting follow-up from mammograms, and increased screening has reduced breast cancer rates in certain zip codes where the van goes. And this is over like a 10-year period of time. So there are programs available to counter some of this. And then, of course, there needs to be environmental cleanup at some point. There's also patient fears and mistrust of the medical establishment, and I think we've talked about that. So patient stereotypes, there are all kinds of stereotypes, and this is my favorite one from living in Nashville, that there were some people who did not want surgery and open surgery because the folklore was that once you open the belly, if air hit it, it would spread, okay? And that was something very particular that I encountered. I'd never heard of it before moving to the South, and that's a very common street lore, as I call it. And so what's really interesting is that we've gone beyond the street doctor or your auntie who's like the local family doctor, and now we have Dr. Google and Dr. TikTok and Dr. Insta, and so we have more of the street lore we've got to counter, and Dr. Chat GPT, right? So we have a lot that we have to deal with. Certainly, the word cancer is very frightening to a lot of people. And for a lot of people, the word cancer equals a death sentence for some people. And I started out with that American Cancer Society cancer letter showing that a diagnosis of cancer does not equal a death sentence. 70% of people have, there's a 70% chance of cure for a lot of cancers. There's a lot of religious overlay, particularly these come from when I worked in the South. There's, my faith will heal me. If I say the word cancer, it means I'm claiming it in some kind of way. So, and so we spent a lot of work going to churches and talking about naming doesn't mean that you're owning something bad. It just means if you name it, we can then address it and start treating it. But there's some biblical references related to claiming something that, I had to learn in working with church communities in the South. And then a lot of people don't trust doctors, period. Just forget about the historical overlay or whatever. They're just, you don't trust the medical establishment, you don't trust doctors. And we talked about this over lunch, that people will trust somebody selling them something on the internet, or trust the friend of a friend who told them about something that makes them feel better, rather than an expert sitting in front of them. And we have to do a lot of work as the experts to overcome that barrier. I think one way, and really important way, and you all really model this here, is having peer support groups. All the kind of peer support that you have here, and Let Every Woman Know. But this is an example of a peer support group for Black women diagnosed with endometrial cancer called ICANA. And Dr. Kemi Dahl started it, but now it's its own nonprofit. And what's really great about this is the women part of this group are educating each other with medical evidence that's been provided by the medical establishment, but it's almost like a translator. Again, having somebody to say it's okay if you don't have peace with your doctor, or if you're not comfortable with something, make sure you find that, because otherwise it's going to be really hard to go through treatment. What to expect, how to manage side effects. So there's this team of people supporting you outside of that traditional medical establishment. And I got to say, there are lots of approaches that have been really good in addressing disparities and reducing disparities. This example here is about patient navigation, and really showing that if you had a patient navigator and you were living in a rural area, there was a huge change in participation and an increase in clinical trial and clinical research. Went from 19% to 40% if you have that connection with a patient navigator. And so I think that that's very, very important. So this is one example. So peer support groups, patient navigation is another way. And then really importantly, on a macro level, advancing policies towards achieving equity. And this is just, long, hard work to really put pressure on our legislators to make sure that they're funding NIH and the NCI so that we have clinical trials, that we have investments in education programs. And, it's really, really hard right now in this particular time in history when a lot of this is going away and a lot of funding is going away. But I think ultimately, if we don't push for this, we will all be impacted by increasing healthcare costs and increasing disparities. So I do want to mention a few things that I think will counter some of the disparities on an individual level and on a systems level is we have to diversify our cancer care workforce. This data is from a few years back, but it hasn't changed much. Only about a third of all oncologists are women. And maybe 2 to 4% of practicing oncologists are self-identified as Black. And no more than 10% of nurses in the United States are Black. So the people Black patients are encountering are just a small fraction of the cancer workforce. And so this is one way you can increase trust amongst patients. Here, this is in 2023. I have a connection with Meharry Medical College, which is a historically Black medical school. I taught there for 4 years, and it's just a wonderful place that I've made connections with students. I'm talking to students who are interested in OBGYN, and the room was packed. So this gives me hope for sure, and I continue to stay connected with Meharry, even though I don't work there anymore. So I chose these 2 talks today because I think they're connected. We really can't move forward on an individual level if we don't have a therapeutic partnership for cancer care. If you don't trust your cancer provider, physician, nurse practitioner, or PA, it's really, really hard to be involved or engaged in your own care. If your cancer care provider physician is not trustworthy or doesn't have the proper credentials or expertise or medical knowledge, and also the character and integrity to take care of you and show you how much they care, that becomes difficult. Of course, each patient comes with their own lived experience, self-knowledge about their body, their culture, and their communities. And how can we engage all of that to improve care? So striving for health equity is imperative. It's a way to overcome these disparities that we are still experiencing. It's the right thing to do. It makes economic sense, and it improves quality care for everybody. So back to the Reverend Dr. Martin Luther King Jr., who said the time is always right to do what is right. Thank you.
Thank you so much, Dineo. That was really powerful. So on point. Moving on, wanted to bring Audrey back up to the stage to give us a talk on a conscious approach to death. So, Audrey, thank you so much for taking on this topic. I really look forward to hearing it.
Thank you. So I have a Garmin watch, and this didn't even happen when I was getting the vaginal radiation, but in this last presentation, my watch said, "You seem stressed. Take some deep breaths." So before we enter this new topic, I want everybody to stand up right now because we are alive, and let's just feel, like raise your hands up in the air, dance around a little bit. We are alive. Wake up. Because this is not too bad of a discussion. So now you can have a seat. Where is that? Okay, so during this presentation, what I hope to share is some of the challenges with meeting death consciously, and to share some of the tools and practices to help walk towards the path of death and dying with love and courage. My goal is to help you think about the preparation to either face your own death or walk with someone who is dying, because sooner or later we're all going to be faced with that process. I will share a couple stories of how these tools helped two people have good closure and to meet death well. This perspective that I will share comes from my personal experience of walking several people on the path, and it also comes from my participation and completion of a sacred death care training program. So living and dying, it happens at the same time, and every breath we take, we are one step closer to dying. And most of the time we can ignore this truth until a serious diagnosis makes it impossible. And cancer often forces death out of abstraction and into daily life. But it can happen to any of us walking home tonight or driving home tonight. So there's a book called The Call to the Far Shore by Nancy McMillan. And she writes, to approach death with fuller consciousness might sound morose or daunting, something to hide from rather than to meet. But in practice, it is a transformative act, radical even. And the surprise is that most of us will find death not as frightening as we've been taught, but rather gentle. There's another quote, and dying and being born are the two most important thresholds of human existence. So there's two main challenges that I think we face when we're walking towards death. The first is we live in a death-phobic culture. Facing death is difficult, and often I find that individuals are afraid to talk about it, families and friends are afraid to talk about it. Some medical professionals find it difficult because they've not had the training to talk about death, only in how to prevent it. There was a 2024 multinational study that found some oncologists emotionally distance themselves from their patients when they must have that difficult conversation because they feel guilt, a sense of failure, and moral uncertainty on how to share the bad news. So I find that people think if we don't talk about it, it will not happen. But talking about it actually helps us to integrate it, what is unfolding. The next one is death is medicalized. Medicine treats disease and tries to extend life. It's extraordinary at treating the disease. The advancements in technology, diagnostic tools, and treatment interventions is truly astounding. I have profound gratitude for the treatment I received after my cancer diagnosis. But sometimes medical treatment keeps the body alive while neglecting the soul, and sometimes the cure becomes worse than the symptoms. Preparation ahead of time, knowing the risks, benefits, and alternatives is really important. And this information can come from a variety of sources. It can come from your own self-exploration. And at the end of this, there's a lot of resources on books and websites and podcasts. Palliative care physicians, spiritual counselors, there's a death doula, death educators, maybe even a friend or a family member that has done some reading on your behalf. So we need to go beyond medicine when facing a terminal diagnosis and start to prepare our mind and our soul for the inevitable. So when cure is no longer possible, how do we have unconditional cooperation with the unavoidable? We can fight disease, but we cannot fight death. The question is, how do we meet it? And throughout the past few years, what I've learned is the more that we prepare for death, the more fully we experience life. Grief will always hurt, but preparation, honesty, ritual, and love can make it bearable. And there's no perfect death. There's only a death that is met well. So I'm going to talk about 3 ways to help prepare the mind, the soul, to face mortality in a more conscious way. The one is just this natural cycle of life. In the book of The Call to the Far Shore, Nancy encourages readers to see death not as something to fear, but as something as part of the cycle of life. And we started this conversation with the land acknowledgement. Paying respect to the native people, those who are deeply connected to nature and the ways of the land. It is through them and those who have learned from them, through their stories and teachings, their connection to nature, and that everything has a beginning and an end. Each day is a birth and a death, from sunrise to sunset. And each year we cycle through the seasons of spring, summer, fall, and winter, where there is birth, growth, death, and rebirth. There's a book by Margaret Rinkle that's called The Comfort of Crows, and she writes 52 chapters that follow the creatures and plants in her backyard over the course of a year. And throughout this year, she develops a portrait of joy and grief. Joy in the pleasure of the natural world, and grief over winters. And she incorporates the changing rhythms of human life. So turning this rhythm into the natural world and what is happening around us every day can help us on our journey and our preparation for death. Practicing those small losses that we experience every day from nature, and not holding on to anything too tightly. The second is navigating life. No one goes through this life without turbulence and storms. So we want to know how to adjust the sails to get to calmer waters. Societal changes, climate change, the effects on our natural world, illness, loss, grief, and dying, it's all part of our daily lives. And we cannot prevent this change from happening, but we can change how we meet it. And facing death and dying consciously means educating yourself about the unfamiliar process so that you can better navigate your way through. And talking and preparing allows us to face the transition in an open-hearted and conscious way. There's a verse by a poem that was just introduced to me last week that I thought would be poignant, and it says, on this planet, nothing is permanent. People and things will come and go. You will fall in love and form sentimental attachments only to lose everything you hold dear. So cling to nothing too tightly, even yourself, and when it's time to let go with grace, for nothing is owned, only borrowed. And that's by James McRae. So in our daily lives, we hold both love and joy, but also grief and loss. And when we numb grief, we numb love. So we have to learn how to hold those two together. This third way is a more directed preparation, and this comes from the Conscious Dying Institute. And it's an exploration of the 5 key domains. And this first one is the physical. And it's working on acknowledging and honoring the wonders of our body. Performing ritual acts to help honor how our bodies have served us and how to say goodbye to the loss of our function. Establishing comfort techniques and managing symptoms as opposed to focusing on cure when there may not be a viable option. In the emotional, it looks at what needs to be felt, expressed, forgiven, or healed. It focuses on relationships, repairs, and closures, forgiveness of self or others, and establishing or welcoming emotional support and setting boundaries. In the spiritual, it focuses on meaning and purpose of our lives, our beliefs about life, death, and dying, developing and implementing practices that help find inner peace, whether that be through prayer, meditation, ritual, nature, music, or legacy work. And the mental, what do I need to do to help understand what is happening? How do I have to communicate this to others? How do I understand the illness, prognosis, and care of the options? And making informed decisions about the treatment. Practical, what needs to be taken care of so others are not burdened? That might be the advanced directives, pulse, deed to the house, wills, possibly planning your own funeral, celebration of life, writing your own obituary. So now I'm going to talk and share just two stories that kind of apply those principles. One happened over a period of time where they were able to go through those 5 domains, and another one happened fairly suddenly. So this first one, her name was Liz, and she was actually my best friend of 30-some years. So she died of metastatic breast cancer 2 years ago. She chose to do medical aid in dying after a cure was no longer an option. After several years of radiation, surgery, chemo, the acceptance began to set in. And although there was some preparation along the way, it was probably in August prior to her passing in February of 2024 that she chose to go on that path of working with a death educator / doula and went through those 5 domains. She and her partner worked through those, and so that there were no words that were left unsaid. She was a little bit controlling. She wrote manuals and tasks for everything that they shared in their life. Many manuals. She participated in a videotaping about herself. A friend from high school was starting a new business about interviewing people, and she was her first client. And so she talked about the things that she valued, the people that were important to her, the people, her professional life, how that gave her gratitude. It was kind of like an NPR story core. She gained clarity of what she knew to be true for herself, and that was to stop treatment before the cure became worse than the disease. She was able to reach out to her brother and a close friend that had some unresolved issues to enable that she wanted to leave this world and have forgiveness and not have anything left on the table. One of the rituals she did after she resolved those relationships with each other is she went to a river, had a rock, tossed that rock into the river, and then just watched it disappear and let those feelings disappear, because she wanted to leave this world with love and joy just how she lived it. In writing some of her legacy, through that process, many of her words were conveyed in her celebration of life. And that was really special to have her words really exemplify who she was as a person and not somebody else reflecting who they thought she was as a person. Some of the rituals, she chose February 3rd, 2024 to be the day that she would do medical aid in dying. So in 3 days, 2 weeks prior to that, I should say, she had all her closing with some family and some more distant friends. And then in the final 3 days, it was a group of 5 of us. Yet there were rituals that we did with people all over the country and actually all over the world. And that's that top picture up here where there's 3 candles. So at night, we would light a candle. We would share, and it was also oftentimes on altars. So people all in these different houses all over the country built altars, had candles. We would light the candle. We would send pictures to each other, and we were just feeling that love. And we would blow out that candle. It was like, okay, 2 days left. Next night, same ritual. It was slowly helping us all to integrate as well as her to integrate what was happening. So we did that up until the last night. This picture on the right is called a thread ritual. So there was 5 of us that each took a different color thread, and we would go up to her in her hospital bed at the house, tie a loop around her wrist and one of around ours, and we would say our goodbyes and then cut the thread. So she died with those 5, and let's see, that went on February 1st. Mine stayed on my wrist. Now, it is a thin thread, and I do a lot with my hands, and I garden, and I work on patients, and I'm washing, I'm showering, I'm running, I'm doing all these things. It stayed on until June 28th. I have no idea how that happened, but it helped me get through her celebration of life and helped me get through like those early grief stages. So ritual acts and preparation and connection can be really helpful to the community that's being left behind as well as the person leaving. Because on her final day, obviously there was some solemn times, but there was also dancing, joy, laughter, and she truly did leave this world the same way she lived it, with pure joy. So that first picture over there with the snow, that's kind of what was happening. That was the weather as she was taking her last breath. And this is a sleeping ute. It's a mountain down in southern Colorado, and that was the evening. It was just kind of comforting to see that beautiful sight and knowing she was up there providing us that beauty. The next one came very unexpectedly just 3 weeks ago when my neighbor called me on a Wednesday morning and said, I feel like I'm dying. And this is a 79-year-old woman who had not used Western medicine other than she thought she had a urinary tract infection a couple weeks prior, to which I took her to urgent care. So I didn't want to, I'm like, she is not dying. But I didn't want to discount that for her, so I went across the street and I measured her pulse ox and her blood pressure, and her pulse ox was in the low 80s. And I was like, did you know this? And she's like, well, I was at the doctor's on Monday, and they said, yep, that was in the low 80s, and I should see a neurologist for my dizziness. I said, well, I think we need to go to the ER. And so we did. And it turns out it was acute myeloid leukemia. But when we get to the hospital and they take that blood work, and the emergency room physician came in within 15 minutes and said, I think you have leukemia. I'm going to send in an oncologist. And he walks out. And so she just looks at me and she's like, what does that mean? And so we talked about it. And while we waited for the oncologist, she just started sharing things that she wanted to get off her chest with me. It was as if she really didn't know she was dying. So I spent the next 5 days with her in the hospital to help her process the information because she did not know how to navigate the healthcare system. So one of the things that came out is she had a complicated relationship with her daughter, and she raised her daughter as a single mother and was not feeling loved. Her daughter was living in another state with another family nearby and had new grandchildren, and she just felt like the neglected mother. So we worked through some of those feelings, and that if this was the end, it would be important to resolve this issue. That was one of those things. So we did a crash course in those 5 domains. And what was interesting, I think some people, even when you don't know it's coming, somehow on some level you know it's coming. Because this past year, she would constantly ask me questions about death and dying and what I was learning. And I thought she was just really being interested. But I think she was trying to process for herself about the end of her life. And she was so open to those discussions in those last couple days. So much so, and she was on track. She would have friends come to visit, and she didn't want anybody. She's like, I don't want company right now. And she wanted me there, and she just then would want to talk about these issues. And so I found it really, I was very grateful to having the tools to help walk her through the path. I wasn't uncomfortable talking about every issue that she had. What did the chemotherapy look like? What were the blood transfusions going to look like? And did she want to do that? And she concretely said, no, I do not want to do that. So when the confirmation of the diagnosis came 2 days later, and the oncologist explaining it to her and what the treatments were, he completed everything he said, and she goes, thank you, but I don't want any of that. And he was incredibly compassionate and gracious and said, I completely understand. And it's my role that I have to explain all these treatment options to you. But now I'm going to explain the other treatment options. And he really talked to her very well about hospice and comfort care and what was available to her. So she had not shared anything with her daughter in regards to where was the will, where was the deed to the house. She didn't have her money in a bank, so where was that money? So those are the things that we planned out. And then, then I wrote everything down. Knowing the conflict between she and her daughter, and she didn't have the energy to talk on her phone. So this is Wednesday, we went in the hospital. On Saturday, I had been with her from Wednesday through Saturday. I was completely exhausted. I'm like, I need a couple hours break. I left the hospital, and then I get a text message from her, and she goes, I'm starting comfort care. She was on 15 liters of oxygen, had taken it off, stopped everything. Her daughter texts, did you know this? I'm like, I did not know this. And the daughter, what should I do? And she's like, I don't know if my mother wants me to come. I'm like, it's not about her right now, necessarily, right? It's also about you and being able to grieve and live the rest of your life without your mother. And so if there's anything that you want to say or do, come. And so she did. And she got to say the goodbyes. They got to resolve the issues. Both of them felt so much better about having that time together before she passed. So part of what Pamela's daughter had come out to do, and I did not know that she had her PhD in something with climate change and had worked with grief. So she knew about this honorable closure, which is these four components that we want to always have. And that is, I love you, I forgive you, or please forgive me. I forgive myself, maybe, for actions. Thank you, and goodbye. And those first three I have started to do with people in my life. Because I don't know. If something tragic happens, then I can just say the goodbye. The forgiveness portion is I think that's a heavy one for individuals. And Stephen Jenkinson talks about letting love in and having things be a village-making event and bringing things together. And when we can forgive ourselves, we can forgive others, we're able to let that love in a little bit more. And at the end of our life, it's really all about love. And every day, it should be all about love. So my invitation today to all of you is that there is no perfect death, and grief and loss will always be hard, but preparation, honesty, ritual, and love can make it bearable. And when cure is no longer possible, connection always is. Talk about your end-of-life wishes with those whom you entrust your care. Talking about death can help with closure. It can make meaning, whether it's months, weeks, days, or even hours, and especially when it is an unexpected sudden event. And so my invitation to you is to start learning and talking about it now. There's some excellent books, podcasts, websites to help guide you. I have a couple pages on the end of the the presentation. But I also looked up, there's a thing called a Death Cafe, and there's one right here in Anchorage. So a Death Cafe is it's a national kind of organization, and there's ones in different states. And so it's a place where people can go and talk about death and dying. There's also drafts over death as well. There's not one in Anchorage, though. But I encourage you, there's just so many tools and resources out there. I think COVID really brought death to the forefront, and there's a movement right now just to provide education for individuals, because we got to talk about it. Thank you.
Audrey, wow. Masterful. That was really, really incredible. And that's such a hard topic, and you brought so much meaning and heart and wisdom to it. So I really thank you for taking that on. deeply. Thank you. All right, so we're going to close out our conference here today with a talk by Dr. Annie Alaniz. This talk may go slightly over 15 minutes, so we're going to let it run because hopefully it's going to leave us all with a very inspirational feeling as we go forward. And then we'll see as we close whether people have questions or whether we want to just let it be at that point with all of this incredible information to just ponder and move us. So Dr. Annie Alaniz is from Malawi, Africa, lives in Houston, Texas, and works at Texas Oncology.
Okay, I'll try to see if I can make it 15 minutes. You should have probably just played this. I feel awkward standing here. But do I just click it? The video?
In Malawi, it's Annie.
I'm Annie Alaniz, and what else do I say about myself? I'm a gynecological oncologist, so I take care of women that have cancer. I do surgeries for those cancers, and I also give chemotherapy.
Annie grew up sharing one room with her 8 siblings. Statistically, she shouldn't have amounted to anything. She wasn't just poor, she was a girl. But Donna from Texas met Annie on a mission trip and offered her the chance at an education.
I was told I was insane and it was crazy. I was bringing this unknown village child into my house. And yes, it's one kid, but to one kid, that's huge. But she ended up the homecoming queen, the Miss Spirit Queen, and the valedictorian of that high school.
Now every year she climbs Mount Kilimanjaro to raise funds for children who were once like her. Every year. She has also climbed to the top of her field as chief resident of her hospital in Houston. And back in Malawi, she's built 12 children's homes, a primary school for 400, a church, and a clinic treating 35,000 patients a year. Annie is giving tens of thousands access to the same opportunity she was once given by Donna.
I think the story that really affected me, Mom had showed up with this child who had had diarrhea, and she had walked like 15 miles maybe to come to the clinic, and she was very dehydrated. And my dad knows this procedure where you can do, they're called interosseous needles, where you can actually put one through the bone when you can't find an IV because the child is so dehydrated. He couldn't start a central line because he didn't have any of those things, and I knew those things existed here, but they didn't exist there. So I kept throwing him ideas of things that he's like, oh, don't have anything for that. Nope, don't have anything for that. So now I was starting to see all the things he didn't have at his disposal. And then now it was becoming clear to me the gap. And I just remember feeling desperate because, what else could we do? She was becoming more and more pale and less responsive, and was just sort of laying there. And I think I had exhausted everything that I could think of from the limited medical knowledge that I knew, and it became clear that we weren't gonna help this baby. And so I was there with my dad and watched her die. Her mom wailing, and she was by herself. My dad was helping her tie the baby on her back. I realized this woman was gonna walk back home for 15 miles with a dead baby on her back. Really was healthy 48 hours before that. I couldn't take it. I just lost it because it's just so senseless. I remember the nurse coming and saying, oh, it's okay, you don't have to cry. This happens here all the time. But I was like, why? Why does it have to be? What makes that baby less important on the planet? And I think that is some of the things that drive me every day, because I don't know why being born in Malawi just stacks everything against you, that just makes you a non-entity. When you don't see yourself in the face of someone and you can't see you in their shoes, it is very difficult for people to identify themselves with that as something that could happen to them and not just look at it as an African problem. It's all of our problem.
All right, so, oh yeah, there's a mic. Sorry about that. All right, so I would just sort of start this sort of like a background. I was just trying to get everybody caught up. I've come here and talked about this quite a bit. I feel like I should get a second citizenship in Alaska. Anyway, so Salima District Hospital is sort of like the district or the government hospital that's just sort of right outside, where I grew up. And so this is the referral center. So as you see it in the picture, this is a catchment. It covers about a catchment of 560,000 people. And so any complications that happen in the surrounding health centers, patients are sent here. And often, just because they don't have, a lot of space and resources, it's usually very crowded waiting rooms. Patients will actually camp out and sleep in the waiting room overnight, and just that way the line would keep going. They don't want to have to start over to the back of the line, so they just bring all their stuff with them. And some patients actually don't make it out of the waiting room and don't even see, providers if they're really sick. Some will actually die in that waiting room. The labor and delivery ward, again, they're getting all the referrals from the surrounding villages, so usually really crowded. I remember reading a very sobering birth supply list where the women are told to bring, those buckets that you see next to them. They bring the chitenges, which are the local cloths, and then, sometimes even ask them to bring a razor and a thread, because sometimes they may not even have cord clamps and they would have to use those, and then a trash bag, because if the few beds that they have there are crowded, often the women will lay on the black trash bags and deliver there. Most sobering is that my mother gave birth in this hospital to some of my siblings. And so the operating rooms, these are the two main operating rooms. The one that you see with a green cover, that's their main operating room. And then the one you see to the side is sort of like their minor room. But because, when you have a catchment of 560,000 people, and those are the two ORs you have, that minor room is actually not minor. And what you see there is actually the only monitor they have in there. One of those times when I took that picture, we had actually done a hysterectomy on a woman who had ruptured her uterus, waiting for her turn to get a C-section. The only way I could tell that she was still alive was that little heart monitor was beeping very quietly when she had actually stopped moving, because she was under spinal anesthesia. At some point, I think she had bled so much that she wasn't really moving. She was fighting us a bit, at the beginning of the procedure. And at some point she stopped, and I would look over and ask if she was alive. And it was sort of like, well, the little monitor was just sort of showing signs that there was a heartbeat. She walked out of that room with a hemoglobin of 2.9. She survived. It's sobering to me every day because I get to live between the two worlds. This is one of the supply walls just outside the OR that I use here in the US. That's just a suture wall right outside of my room. On the other side that you see that's the entire supply room for the Salima District Hospital. That is all of their sterile sets. So in fact, when we're doing surgeries there, we open one of those sets. We've loved we realized very quickly that us as surgeons are very terrible at managing our, OR supplies. And one of the best things we've had is some of the scrub techs have actually come to Malawi with us, and they can look in that and they'll be like, you have these 3 things and that is all you're getting. And we have learned how to do a surgery with maybe 3 or 4 instruments so that we can actually use that set for multiple patients, because if we use it all on one patient, we're unable to do cases for the rest of the day. And so in the background of this, and I've shared this before, this is, Port Taria was founded, sort of to relieve some of the issues that were happening at the local district hospital. And so, we've got the campus is sort of like what I was showing you up here. Up at the front of that is where we have the medical clinic. We've got a child development center. We have a primary school. And off campus, we're actually in the middle of building high school. We have a computer lab there for the children. We've got some, sort of agricultural products that we process in a mill. And then, of course, the outpatient clinic. And then very recently, in addition, has been the surgical center. And so we actually house kids. For us, it's always preferable that the kids live with a family member, but there's a few kids where there's actually absolutely no one that can take care of them. In fact, we have a good number of kids that get brought in from the hospitals and the social services for us to take care of. So that's part of what we do. And we do provide educational support for the kids. It's very important to me because I actually truly believe that the future of Malawi is in the education of our children. I mean, they're brilliant minds. They just need the lift up. They're fully capable of doing everything that I'm doing, even right now. So I really think that the answer to what's going on in Africa lies in the minds of these children. So providing them equal opportunity to education is ultimately going to be what will solve the problems there. So that's our primary school. And then again, like I said, off campus, there's a high school building that's due to actually open in September. And then we do have some sustainability programs, sewing. We have, like I said, the maize mill. We have agricultural products, and all of these things are things that we teach the kids. Our outpatient clinic, like you hear, is very busy. We see over 35,000 patients. Our focus is women and children, but we do see men. But, more than 70% of the patients we see are women and children. The birthing center is open. We're doing deliveries, but then very quickly we realized that whenever women would actually have complications, we would have to send them to the district hospital. And like I said, with 560,000 people, often when they get there for the C-section, they're in line. And, things would end tragically. So often when you'd say to a patient, I need to refer you to Salima District Hospital, they would start crying because they were literally feeling like you're sending them somewhere to die. So we realized that we needed to increase capacity. It's not that Salima can't do these things, it's an issue of capacity. They have skilled staff who do the best that they can with very little, but with, one operating room, it just doesn't leave much room for them. And so it was actually, I don't remember if were we traveling from here? I couldn't remember. One of these times we were kind of talking, we had just come back from Malawi. I was in Malawi, and there was really tragic experience with a very young patient who also, was essentially trying to die from a uterine rupture, and she had delivered multiple dead babies, and most of them really associated with access. And I just remember having this moment of thinking, I've been coming here every year, and that is what we're doing really making a difference, and I just sort of felt, somewhat helpless, and the problem just felt too big. And that what we were doing was just sort of like a drop in a bucket, and it wasn't really doing anything. And so I think it was on the trip back that we kind of started to discussing how can we increase the capacity for surgery. So there was a moment where actually Joni and I think sat down and we were drawing something on a napkin of what an OR would look like. We didn't have any resources. And so we had heard that there was a grant that was going on with Direct Relief at the time. Somebody had donated money, but they actually wanted it for health equity, but it was actually only for US-based organizations. So we were rejected. But what ended up working out was that not very long after that, we had a good friend that, did I skip
Hello.
something? Oh, don't worry about that. We'll skip that. We had a good friend that actually was associated with an organization with Deerfield. They're based in New York. We ended up actually using the exact same rejected grant from Direct Relief to Deerfield, and they actually ended up giving us what has been a total of close to $500,000 now to actually start the surgical center. And so this is sort of like the newest building as you see it. And so what we have now is, you could see the Salima District Hospital there, and that's our new surgical center that's right behind the birthing center. You can kind of look at the difference. There's the main OR, and then, this is our main OR, and we have 4 of these operating rooms. And one of the rooms is actually going to be big enough that we can, where we actually were able to acquire laparoscopic equipment, and we should be able to do some laparoscopic surgeries. And in a place where blood banks aren't really available, that's going to be really big in being able to do minimally invasive surgery with a lot less blood loss. Right now, every patient that's having surgery have to bring their own walking blood bank. Like literally people in the villages know who's their blood match. And so before every surgery, we actually test which relatives. We keep them on the side, and when they need blood, the relative goes in, gives the blood, and we give it to the patient. So everybody gets whole blood. My own sister actually needed a surgery, and some of the physicians in our group were the ones that actually ended up giving her like 3 units of blood. And actually, up until then, she was not going to be able to have surgery, and she was struggling with heavy bleeding and fibroids. And it was not an option actually for her. She wants kids in the future. A myomectomy in Malawi was just deadly. So to me, it was like live with a huge uterus and bleeding and get iron versus, get a myomectomy and die because there's no blood. And so, you could see sort of the walkway, Salima District Hospital, and this is what we have now with a surgical center. Often at Salima District Hospital, we have major problems with sterilization. I think we sterilize most of our equipment with spirit. You see, like, we're reusing even some of our suctioning. So we actually just dip it in spirit and leave it overnight. And then the next day, reuse it. And very soon, we're actually getting sterilization equipment there for us and they were for the district hospital. And so, I've had a really amazing connection with the community here in Alaska. It will be completely lost for me to not express what a huge impact Alaska has actually had on a project that's in Malawi. I think the first year we did a fundraiser here towards this. They raised like $200,000 that has actually gone towards this because, like as I mentioned, we got not quite $500,000, but close to $500,000 from Deerfield, but that didn't get us anywhere to actually even do the inside finishes. So almost all the donations that have come out of Alaska fundraising events have actually allowed us to complete the project, or we wouldn't have been able to finish it. And so there's been a lot of action. This is one of my really good friends, Nancy Kratz. She actually went to medical school with me. She's an ER doctor here. And also was actually connected. I don't know how many of you know the Nice Wonders. They actually had a project based out of Malawi. He's a family practice doctor here. I think he's retired now. He actually was living in Malawi when it was under the British. So he knows some history of Malawi that I'm not even, like he tells me what happened before Malawian independence, what books were not allowed, and how he worked through, a government. It's like history about Malawi that I don't even know. So it's quite amazing. And he had an entire actually group of people here in Alaska, Anchorage, who'd been traveling back and forth to the organization that he has just right outside of Salima. So that's how Nancy and I got connected. And so, she's come to Malawi. She's done 3 Kilimanjaro summits and has done countless medical trips. She brings her daughters with them. They like to hold the goats, and I like to remember them. Don't cry when they end up being your lunch. This is something I try to tell people when they come there. Don't get to touch the goats. They are food. And then Hannah is her oldest. She actually did an amazing project because on one of the trips when we've gone there, sometimes blood is available, but there's actually no blood giving sets. So we've actually seen children, with malaria because it attacks red blood cells. They'll get very severely anemic, and that's often how they die. And they would have a relative that's available to give blood, but they don't actually have a set to put the blood in to give it to the baby. And then you actually watch them die with blood available, but no blood giving sets. So actually one of her projects in her biomedical engineering program at Duke, she's developed this sort of reusable blood giving set and has been working with the College of Medicine in Malawi to try to see if that's something that we can actually implement. But that's just been the impact of, her trips to Malawi and kind of wanting to make a difference and give a gift that keeps on giving. And, this is Ava, one of the high school seniors. I actually went and summited Kilimanjaro, raised money, and also spent some time in Malawi. And she's also right here in Anchorage. And then Julie was one of our teachers. I spent a lot of time with our kids, and you can see her doing some of the craft projects with them. Ben is actually a son of, she's a pharmacist here locally, and he's actually aspiring to go to medical school. So that was him after he was assisting us with one of our surgeries. And so, and then Jennifer, of course, that's mom. She actually was helping in our pharmacy and kind of helped us with some of the processes of keeping inventory, of the medications that we have. And then Carissa, nurse, easy. I mean, she had plenty of things to do while we were in Malawi. We love our nurses, our scrub techs, our ultrasound. And then Dr. Natalia Saprianka, you guys probably know her. She actually also climbed Kilimanjaro with us and spent a lot of time with actually the local clinical officers. She did a lot of C-sections with them, just sort of teaching them some of the, techniques, sort of learning how they work through some of the difficulties. Because she's also working in an environment with tools that are so limited. So, just a collaborative effort between her and the local physicians was just amazing. And she's a good sport. And then Ari, Joni's daughter, she's actually gone almost every summer. How many trips now? This will be her fifth? Yeah, she's going back for the fifth year, and she's gone every single year since the first time she came. And so one of the things she implemented there was a compost program, and she did it with all the kids on the campus. And that's one of the things that we use for fertilizing for the gardens that actually feed the kids there. Alex Thomas, her mom is a general surgeon here. She actually spent 3 months in Malawi working alongside this guy. So that's my sister on the other side, and then one of the clinical officers. And then Raquel, just recently, I think that was it a year and a half ago, she was over there. She volunteered also for 2 months. And when she was there, realized that a lot of kids, if they ask them what they want, it's also very humbling because these kids could ask for clothes and phones and things like that, but they wanted books. They want books to read because it's amazing how most of them sometimes don't even have access to the books. And so, I think that there's so much inspiration that you can find in the books, and these kids are brilliant kids and they want to read and they want to learn more. So she actually came back with inspiration to start a library. And last year, actually, Ari and some of the younger group that came in, they converted one of the classrooms into sort of the beginning of a library. They divided up age groups. And so that's actually the product of one of the things that they did. Linda Moore and David Cooper are here. They're associated with Alaska Medical Missions. The very first shipment that actually went to Malawi and our birthing center came from them. All the bassinets that we actually have in the birthing center are all from here, Alaska, and they went through a container with Alaska Medical Missions, and the funding to actually ship it all came from Alaska, and that was great. I mean, you can imagine at the district hospital where the women don't have adequate beds. In our birthing center, every woman is in a bed. Nobody's delivering on the floor. There's actually mattresses on each bed, and that's it seems like a simple thing, but it's big, there to be able to have that. And so this is the shipment from Alaska Medical Missions, and then Kevin and Karen were recently involved with the process of finishing the OR. They actually donated money towards us getting 4 brand new anesthesia machines. These were actually created to work in environments like this, because sometimes you can't just take an anesthesia machine here and go lock it in there and think that it's going to work the way it works. So these are actually meant to be able to store electricity. So if you lose electricity, they'll actually keep working for another 6 to 7 hours before they go out. They also actually have their own ability to create oxygen. And so they're actually meant to work in this environment. Within Africa, they have actually the biomedical engineers that actually come out and support. They set them up, they train their staff how to use it, and then they're available to troubleshoot anything that you need with them. So an amazing gift from Kevin and Karen that we have there. And they're already actually there and in place and ready to go, and they've already gone and trained the local anesthesia. And then most recently here, Providence, you had one of our boys, and it's actually Buzzwell. There's a picture at the top of that. That was actually Buzzwell when he was living at the orphanage. So Buzzwell was orphaned when he was really young. We had him since he was 8. And one of the most brilliant minds we had at the orphanage. So him and another boy actually were given scholarships, and they went to Grand Canyon University here. And then Buzzwell finished his, healthcare administration degree in 2024. And then Providence actually gave him a fellowship here where he was actually learning about OR management. So he has spent a year here going to different parts of the OR, sterilization process, registration, all the parts that can actually help an OR run. And he just left last week. He completed his fellowship. He's in Kansas City, where his host family is. He's going to spend another week there. And then he's headed back to Malawi this month. And he's actually going to be the OR manager for the new surgical center. So again, like I said, you know, the wealth of Malawi lies in her children. And this is a prime example of that. So some of the things that we look at in terms of cancer care is, the issue of access. When we've gone there, right now, I think the International Gynecological Cancer Society has been trying to really train GYN oncologists in low resource areas like this. But like we just graduated our first fellow in November in Cape Town from Malawi. So that's a first trained GYN oncologist who's Malawian other than me. And so often when I was going to Malawi, I was the only GYN oncologist. So there were a few people where somebody came and maybe in a period of 2 weeks showed them how to do a radical hysterectomy, vulvectomy. They would just line up cases, teach them how to do it, and then let them start doing it. So often the holes in that is there's more to treating a gynonc patient, as you've learned this week, than just doing a surgery. There's so much more. You need to know, how do you follow them? What happens when they recur? What options do you have? And so that requires more training than 2 weeks of just showing somebody how to do something. And so, this was a sobering case of a young patient who was actually had like a stage 1B to, I think, cervical cancer. And then because of lack of access and the fact that there wasn't going to be anybody to do surgery, they were going to do neoadjuvant chemo on her. Except that where she went to get chemo, they had chemo, but they just gave her a flavor of the day. So there's actually a list here of chemo. There's some days where she got a toposide and a platinum agent. And then, she would go in another time and she got like a regimen that was for, sarcoma. And so on her sixth, she showed up to every single visit and got 6 different chemos that did different things, but didn't really help her cancer. So when we saw her, she was coming to the hospital bleeding every day. She was bleeding down to 2, bleeding down to 2.5. I think when we came in, like her hemoglobin was like 3. And, her disease was so advanced, like that's what her hysterectomy specimen looked like, and it was really done. So she's just not laying in a bed bleeding to death. And she will recur because clearly, this is, but at least she was able to go home. And then we did work on trying to see if we could get some resources for her to get some treatment. And most places that you will go, you will see that these women will carry their passports, and you will see stage 1B or stage 1, A2 cervical cancer, which is very curable here. But then when you see disposition, it's usually hospice. Because for the average woman who is in the village, they don't have an ability to get to Lilongwe or Blantyre for treatment. And so even at an earlier stage, this is hospice care. So pathology is also one of the challenges. We're actually still waiting to get the rest of our pathologies from our most recent trip that were there in November. And we've had situations where, they'll run out of paper to print the pathology report. So just give us the basic of information. And then, like, if you want more, you actually have to call the pathologist to get the rest of it. So, like, paper even is a very valuable, and they can't print out 15 pages. So they'll give you the basic information. Then if you want additional things, you'd have to call them. It costs $16 right now to get a pathology. So the average Malawian makes $1.25 a day. So when you're in Salima, most women in Salima don't have $16 to pay for their pathology report. So we've actually had to pay cash for their pathologies to be done. And so again, very limited training for local pathologists. Most of them are based usually in Lilongwe or Blantyre, but most of the district hospitals actually do not have any pathologists. So you have to send it to Lilongwe or to Blantyre. And so some of the things we've done is create relationships with some organizations here. Direct Relief actually gets a lot of drugs directly out of the manufacturers. They have enough funding that they can actually put the drugs together and ship them flight. From the time we actually go on our website and order drugs, we're able to get it to Malawi within about 2 to 3 weeks. And that's been huge because it's allowed us to actually have, to help with the most vulnerable patients, and they don't have to pay for the cost of the medications. They also provided us with midwife kits that have everything you need to be able to perform a vaginal delivery safely, including medications like Cytotec are actually packed in there that we use for postpartum hemorrhage. We actually have a pathology lab that's actually the funding for it, for sort of putting it together and buying all the equipment was funded by a pathology group here in Anchorage. That's Dr. Jill White. She's actually been here before at one of these conferences. She was actually giving blood for my sister on this particular day and then turned around to do her surgery right after that. It didn't quite work out very well, I don't think. Did it? Not really. Yeah. Yeah. She had to sit in a chair a few times during the procedure. So she said she can give blood and it doesn't bother her. But, you know, when you're in Salima and it's 100 degrees in the OR and you give blood, it doesn't quite work out well. But, you know, very grateful that she was able to do that. And then we have our hematology lab. And so, you know, like we talked about, you know, we had 9 Alaskans that have actually gone and climbed Kilimanjaro and volunteered there and raised a lot of money to help us. And this next year in June, I'm doing my milestone hike, which will be my 10th Kilimanjaro hike. And so there are 10 Alaskans that are going to join that trip. It will also be the 2nd anniversary of my 25th birthday. We don't have to say more about that. So we won't say anything else. And then we actually have this beautiful quilt that was actually done here. I think Dawn may be thinking about returning back to Malawi, so she'll be hanging this somewhere in the OR. We had a painting that was actually donated from here that was auctioned out. I think we were able to get actually $17,000 for this. And I think this quilt was also auctioned out at one of the events here in Alaska for like $20,000. That went towards the, you know, so this is the event in 2024 and 2025. This was done at Captain Cook. It's been very, very well attended and, you know, very generous donations. And there will be another event May 1st at the same location. So would love to see you all there. And was that the last one? Yeah, we covered a little bit about the cancer program, right, and surgical training. This is a much better done radical hysterectomy. Unlike the other one that you saw. Right now, all our surgeries are obviously open. And there is obviously data now to do most of these cervical cancers as open cases. And so just having the ability to have the equipment, the anesthesia, we do these with patients under spinal because if electricity goes out, they can't ventilate them. And so you can imagine we're doing a hysterectomy open, the patient is awake. Sometimes if they start feeling, they're grabbing you. So we're really looking forward to being able to do these cases with general anesthesia, laparoscopy for endometrial cancer surgeries and ovarian. You know, right now we're trying to build surgical teams where we're going to take surgical teams that are going to be able to go about every 3 to 4 months to help. And then, of course, you know, our ultimate goal is in the future to be able to have radiation. There's some works that they could be radiation coming to Malawi. It's not quite there yet, but I think they're really close. So I think the guy that they were actually training, he's a medical oncologist, and they're going to train him to do radiation. You got to do what you got to do. And so I'm excited that we just have it at all, but the line is going to be really long. Right now, people wait 2 years to go to India for radiation therapy, but it's going to be nice to have some access, though limited. You can imagine one radiation machine with 9 million women and cervical cancer being one of the top cancers in the country. It's going to be really hard to do that. So I think, you know, neoadjuvant chemo and being able to do surgery and things like that is still going to be around for a little bit longer until that that comes to fruition. So thank you, Alaska. I cannot express just how grateful I am. You know, like sometimes it can feel very small here, but I've actually been quite impressed with how sort of diverse the community is. There's such a large international community here. I just met my fellow Africans there from Kenya. And there are several Malawians here as well. And so it's been incredible just to sort of feel embraced by the community. Often it takes years to build trust with people for them to be able to show up to events like this and donate $200,000. And they believe me and believe that what I say I'm going to do with that money is actually what's going to be done. And that is a gift. I can't tell you what gift that is. I mean, I started climbing Kilimanjaro because it was so hard to develop those kind of relationships. And I felt like I had to just put like skin in the game, show everybody that I was willing to do anything and go anywhere if I, that could help me get, funding for this project. But I felt like I was able to come here and there was, acceptance and really belief in what we're doing. So, thank you so much for being, part of this. And April will be their first surgeries in Malawi.
If anyone wants to come to Malawi and experience this and put your skills to work, we absolutely welcome you. Let's just take 5 minutes if anyone has any burning questions for our speakers. Okay. I'm going to take that as no burning. Yes. So thank you all so very much. I want to thank Trent. Thank you so much for doing the audiovisual. We greatly appreciate it. Our Let Everyone Know board members who really made this possible, and Tessa Ely and Marcy Ash are 2 employees, our executive director and our program coordinator. They've already gone to help get the next event set up for tonight, but they've really worked tirelessly for today. And thank you all to our speakers, each and every one of you who've donated your expertise and your time, your very, very valuable time and your wisdom. It really was a fabulous day. All right, thank you. So don't forget to come to the Mardi Gras event tonight. Okay, if you need to scan for tickets, come. If you just want to come bust in the door, I'm sure you'll probably get in. So please come, and that's it. Thank you. Thank you, Heart. So I am